Good morning. This is John Agliata. I'm the Marketing and Communications Coordinator for Shriners Hospitals for Children in St. Louis. And this morning I'm here with Dr. Pooya Hosseinzadeh, who is a Clubfoot specialist, among other things, here at Shriners Hospitals for Children in St. Louis. And we're going to be talking about Clubfoot. So good morning, Doctor.
Good morning, John. Thanks for having me.
Thanks. So tell me a little bit about yourself and how you came to be a doctor here at Shriners Hospital.
Yeah, so I grew up overseas, and when I came to the States, initially lived a couple of years in California, then in West Virginia, Kentucky, Florida, and ended up here in St. Louis. During my residency training, I worked at Shriners Hospital in Lexington, and that's where my interest and love for being involved in orthopedic care for children, and especially my interest in clubfoot deformity developed. I've always loved the mission of Shriners and what they do for kids, and how this great service is provided for kids who need it. And I think that's the reason I ended up pursuing a career that involves taking care of kids at Shriners Hospital. And I believe why I'm here.
Great. So let's talk a little bit about clubfoot specifically. Can you tell me what you mean when you make a diagnosis of clubfoot? What does that mean for a patient and their family?
So clubfoot deformity is actually the most common congenital deformity of the lower extremity. When I mean congenital, means something that the child is born with. And as typically the average incidence is 1 in 1,000 live births. Of course, there are some ethnicities that the incidence is higher and some a little lower, but on average 1 in 1,000, so the most common one. And when you look at the clubfoot deformity, the foot is turned in and is also turned down. So there are elements to the clubfoot deformity that involves an abnormality in the front part of the foot and in the back part of the foot, and also in the ankle joint. And typically the muscle, so it can be involving one side, what we'll call unilateral, or both sides, what we call bilateral. So and typically with the kids who have this deformity, the muscles below the knee are underdeveloped compared to lower extremity without a clubfoot. So it's basically a deformity that starts below the knee joint as far as muscle development, but mostly involves the foot.
Okay. So at what age can a patient born with clubfoot, be treated?
So as far as the diagnosis, I'm going to take a step back, look at the diagnosis. Now with the ultrasound, they can actually make the diagnosis in utero in most of the cases, not all the cases. And sometimes they can make a diagnosis of clubfoot in utero, and actually the child is born and the foot is basically maybe just a flexible type of clubfoot, or just normal variation. So the method that we use right now with the casting, we want to get started relatively soon, because we want to take advantage of how flexible the tissues are in a child, and the younger the child, the more flexible the tissues, and the faster they're going to respond to stretching with cast. So typically, I think ideal age is to get started, within the first 6 weeks of age.
Okay. So let's talk about a child's journey here at Shriners Hospital. When they come here and you make a diagnosis of clubfoot, what's that first appointment like if you were to talk to a parent who is going to be considering bringing their child here? What's that first appointment like?
Sure. So, it's actually one of the diseases in children that we develop actually pretty close relationship with the parent, because It's a long journey. It's not something that, we do one surgery on and the child is done. Um, so the treatment involves several rounds of casting initially, which is one per week, and then most kids will have an Achilles tenotomy to cut the minor surgery to cut minor procedure to have that Achilles tendon cut. Then it will go in braces. So clubfoot deformity, what I tell all the parents when is we can achieve great results with this method, which is minimally invasive, but it takes patience and persistence, and we do need parents' help initially. Bringing the kids every week, and then when we're done with the casting, the bracing part is very important because clubfoot deformity is pretty stubborn. You can get the foot corrected and then like so go back to the original position. So it is very important that the parents are informed about the importance of keeping the braces on and monitoring for relapse of the deformity and doing the daily stretches. So yeah, I mean, I think it's a treatment that really involves the parents, to keep the appointments and also to follow with the instruction as far as the bracing.
Okay. So what would you say is the Shriners Hospital approach to treating clubfoot? You mentioned kind of a three-phase approach. And so what is that approach called, and what makes it the most effective?
So the approach that we use here is called the Ponseti method. It started in Iowa several decades ago, but unfortunately it wasn't popular until early 2000s in the whole country. So what makes the Ponseti method different than what we used to do mostly in the United States before 2000 is, if you look at 1990s and 1980s, mostly these kids were treated with big surgery, which is called a post-medial release around age 1. And there were a lot of complications associated with surgery: overcorrection, undercorrection. Usually the foot looked okay, but a lot of them end up having painful arthritic feet as adults. The good thing with the Ponseti method is minimally invasive. You don't, there's no big surgery performed with it. It uses the flexibility of the tissues at an early age to correct the deformity with casting followed by bracing. So if long-term studies have shown that the adults who've had their feet treated with this Ponseti method in childhood, they do really well, and they're able actually to participate in almost all of the activities of daily living and sporting activities without any restrictions or limitations. So that's actually one thing that we talk to parents about is if we follow through this method, it's cumbersome. It takes a lot of appointments, take patience, but the ultimate results is, your child will end up with or is actually expected to end up with a painless foot that is as functional as a foot that did not have any deformities to form with.
Okay. So does every patient require that minor surgical procedure you were talking about after casting?
I can't say 100% of them, but it's close to 90%. So majority of the patients will require that. Yeah.
Now you've touched on this already about a parent's role in this, and it's a pretty big commitment. Can you talk about that and just as a point of emphasis?
Yeah, sure. So if you look at as I just mentioned, the clubfoot deformity is very stubborn, meaning the tissues in the child's foot really would like to go back to the original clubfoot position. So keeping the foot stretched during that early growth phase of the foot, which is the first 5 years, is very important to keep the deformity corrected. And studies after studies have shown, that the club feet that relapse are those ones that they haven't been actually compliant with the bracing. So it's not all parents' fault. Sometimes the foot is not completely corrected. Sometimes, a child doesn't tire them, but all these things can, um, looked at together. I think it's really important that the parents follow the protocol for the bracing, which is full-time bracing for 3 months, followed by part-time bracing for up to 4 years of age.
What was that last part? Up to how many? How long?
Up to 4 years, yeah.
4 years.
Age
Okay.
4.
So typically, how many casts might a child need during that course of treatment?
So the initial treatment, although it's hard to say, but on average about 4 to 6 casts are required. Sometimes it's less when the deformity is very flexible, but on average, I think about 4 to 6 casts that are applied are required. I think it's important not to really focus on the number of the casts and to focus on making sure that the foot is completely corrected before the child is placed in braces, because if the foot is not corrected and you put the foot in the braces, of course the child is going to cry and they're not going to tolerate the braces, and a relapse of the deformity happens. Just to keep in mind that this 4 to 6 casts is for the initial correction. Sometimes the deformity relapses, which if the relapse happens before 3 years of age, we usually treat it again with another round of casting, which they respond pretty well. Older than 3, they may require a tendon transfer after the serial stretching cast has been performed. And if you look at in general, the relapse rate in children treated with casting is close to 30-40%. So but the good thing about it is that even if the feet relapse and you cast them again, and even if they need a tendon transfer, the outcome results as far as the pain and ability in adulthood will not be affected. So even if you have to do a tendon transfer, even if you have to cast them again, as long as it's successful and you follow the protocol, the results are going to be as good.
Okay. So a lot of parents will ask, because obviously there's concern over pain for their child. Is the casting process painful for a child?
So the pain that they will have is pain associated with stretching, and of course our goal is to stretch them to the to a part that is to some extent uncomfortable but not very painful. But I would say yes, there is some discomfort associated with stretching the feet. I wouldn't consider it like a big amount of pain, but is there definitely uncomfortable when that foot is stretched.
Okay. So some other parents who've gotten involved with this process, they ask why a cast needs to go up above the knee. Why is that so?
So for 2 reasons. One of them is at that young age, if you put a cast below the knee, it can the kids, when they move, they can easily kick it off. So they have a lot of tissues. They have a lot of fatty tissue around that age. And if you only put a short leg cast on below the knee, the child can easily kick it off, and that's much harder to do when the cast goes um, above the knee. And the other reason is actually what we are trying to do with the clubfoot deformity. We're trying to turn the foot out, and as you can imagine, it's a lot easier to keep the foot stretched in the kind of external position when you have control above the knee as well. So
All right.
those are the 2 reasons.
So you touched on bracing and stretching and the importance of that. How long would a child be typically in a brace toward the end of that treatment?
Sure. So we start with the full-time bracing, which is typically about 23 hours a day for the first 3 months. Then my protocols that actually gradually decrease go from 4 hours to 18, and then 15, and then 12 hours. We kind of decrease it every 3 months. And we usually keep them at that 12 hours a day until age 4.
And we talked also about stretching and a parent's role in that. How long will a parent or the child, as he or she gets older, how long will it be necessary to do that stretching that you prescribe?
So, we typically try to keep them on until age 4, but there are some kids who the foot has relapsed and they develop really tight Achilles. Those are the ones that, we recommend that they continue stretching either with a brace when they're asleep, or during the day until age about 7 or 8, as much as they can tolerate. So.
Okay. And is there a chance that there will be a need? You mentioned some of it about casting in the future.
Mm-hmm.
After that 3-step process, you mentioned that there might be a possibility of casting again.
Yeah, sure. So if the deformity relapses, of course, you won't be able to keep the foot that is in the club position and is going back in that position in the brace, and we have to restart casting. So if this happens before age 3, we only, do the stretching casts, and maybe working on the Achilles stretching, and maybe Achilles tenotomy. After age 3, if there is an element of what we call a dynamic supination, meaning that one of the tendons that bring the foot in is involved in creating that deformity, then a tendon transfer could be considered to keep the foot in the correct position.
Now, if you could talk a little bit about that tendon transfer and what that surgery involves, and just some of the specifics about that surgery.
Sure. So tibialis anterior tendon transfer is the tendon transfer that we're talking about. The tibialis anterior tendon is the tibialis anterior muscle is actually the muscle that inserts on the inside part of the foot. Its job is actually to bring the foot up and in. So and there are also muscles that attach on the outside of the foot that will bring the foot out. So in some children with the clubfoot, the muscles that turn the foot out are very weak, and the tibialis anterior tendon is very strong compared to those muscles. So when the child walks, you typically don't see that until the age 3 or 4. That actually the foot, the front part of the foot is turned in when the child walks, and so what we do if the foot has relapsed, and also that element of dynamic supination means the foot is turning in when they walk, the front part of it. What we do is we take that tibialis anterior tendon from its attachment on the inside part of the foot and take it to the outside of the foot. So instead of bringing the foot up and in, actually it will bring the foot straight up. It's a pretty minimal, I wouldn't say minimal, because of course it involves a couple of incisions to move the tibialis anterior tendon to the outside of the foot. After that surgery, they're typically in a long leg cast for about 4 weeks, and a short leg cast, which they can actually walk on for additional 2. And there will be a short-term bracing involved after that for up to about 3 months. But after that, they typically would not require any braces when walking.
All right. So one of the questions that parents often ask when they find out a diagnosis of clubfoot is if treatment here will enable their child to participate in sports or other activities when they are a little bit older. What's the norm in these situations?
Yeah, sure. I mean, of course, I think clubfoot has, different etiologies and different severities. But as far as if we're talking about a normal congenital clubfoot, means clubfoot that is not associated with, spina bifida, arthrogryposis, and all those other syndromes or neurological disorders. Children with a congenital clubfoot that are treated with Ponseti method, and they actually, studies have shown that they are able to participate in sporting activities. As I said, there's some things that are going to be different about the foot because the deformity is below the knee. So that foot always going to be a little smaller. The calf is going to be a little shorter, a little smaller compared to the other side. But in general, as far as activities and pain in adulthood, if we keep them with the method and everything goes as expected, yes, absolutely, they will. I don't expect them to have significant limitations, and will be able to participate in sports. Yeah,
that's great. So is another question that we see with parents when they receive a diagnosis of clubfoot is if it's hereditary, if their children have a possibility of passing that along. What's the situation there?
Sure. So it is. There is a hereditary component to the clubfoot deformity. It's not. We don't have an actual like specific gene identified for it. So it's one of those disorders that is a combination of the interaction between the environment and the genetic predisposition. So yes, if the parents have clubfoot deformity, or if there's a clubfoot deformity in the family, there would be a higher chance of having another child with clubfoot. So I think if you look at it, as I said, the deformity is 1 in 1,000. So, but if one child has clubfoot, the possibility of having another child with clubfoot is about 3 or 4%. It's not high, but it's definitely way more than that 1 in 1,000. And if you look at how it's passed on to the children, so if mom has a clubfoot deformity, this has a much higher chance of it passing on to their children than if a dad has clubfoot deformity.
Okay. So you've written a number of papers about clubfoot and done some research on it as part of your career. Can you talk a little bit about that and some of the exciting things and where clubfoot treatment is going in the future?
So yeah, and this has been one of the areas that I've been interested in, and we've looked at a specific type of clubfoot, like a clubfoot deformity associated with amniotic band. We looked at how the relapses are treated. We've also looked at the relapses that can happen after the tibial anterior tendon transfer has been performed, and we're also doing some other studies now, trying to come up with uniform descriptions of what we call a dynamic supination and what we call a relapse, and how that should be treated. I think the next step in the clubfoot research will be to better understand the genetics and the epigenetics of what happens with the epigenetics is what happens after after birth, and why some club feet are more resistant to treatment than others, and also understanding the muscle weakness in the clubfoot deformity, meaning we know that the muscles that turn the foot out are weaker, and is there anything that can be done with strengthening with some form of therapy that would be able to strengthen those weaker muscles and potentially avoid the relapse that we see.
So last question, what advice would you leave a parent with? What's the piece of advice you'd give them if they're considering seeking treatment with you through Shriners? What would you tell them?
So, what I clubfoot is actually one of those disorders that there's a lot about it on the internet, and there are there's a lot of social media presence from parents and groups with the clubfoot deformity. And what I have found is that parents sometimes go read these things, and they get really concerned of, what's going to happen to them. And as you can imagine, with the social media platforms, the people who are there, the parents, are typically, the ones who haven't had a good experience with the initial treatment, or have had difficulty, or have had like kids with Bort's deformities or of some sort that have struggled with the treatment. So although I think it's always good to, for the parents to increase their knowledge of the Clubfoot deformity, I would suggest that they wouldn't get scared about what they read online, and focus on their child and their journey. And as I said, it's really important to keep up with the appointments, keep up with the casting. The other thing that is important is, if they see any form of relapse, if they see the foot is turning in, if the foot is getting tight, those are never going to get better with bracing, with the continued bracing. So if there is any relapse of the deformity, that should be addressed. I think and I want them to actually stay really involved with the care of their child and in communication with the child physician. And I strongly believe that they would stick to these things, and all kids are going to do great.
Great. Well, thank you so much for your time today, doctor. I know that you have more surgeries to do today, so I appreciate you taking the time, and I know our viewers will as well. So thank you very much.
Thank you, John.